Good afternoon. My topic is renal tubular acidosis. This is a condition wherein the acid is not being excreted from the body. So there is an increase of acid in your body, the acidosis, and this is mostly caused due to autoimmune diseases. So they are majorly not preventable. So coming to the pathophysiology of it. Now this happens majorly in the nephrons. So this happens in proximal convoluted tubule. This is in distal convoluted tubule and this in collecting duct. So what happens here is you can consider this as the lumen part of it, and this where the blood circulation goes in. So here in the cells of proximal convoluted tubule, what happens is when there is bicarbonate passing from the glomeruli to the PCT, what happens is bicarbonates, they combine with acid in the presence of carbonic anhydride to form water and carbon dioxide. Later on, this carbon dioxide gets inside the cells and combines with water again to form bicarbonate and acid in presence of carbonic anhydride. This is a cycle just to get the bicarbonate inside the cell, and then it is shifted to the blood circulation. Now, this is a normal physiology that happens, and then coming to the distal convoluted tubule, what happens is they have cells called as alpha cells, alpha intercalated cells. Here what happens, the major thing is that there is excretion of acid and reabsorption of bicarbonates. That is the main function of in alpha intercalated cells. And coming to the collecting duct, here you have a cell that has ENaC. ENaC is nothing but epithelial sodium channels, which reabsorbs the sodium and pushes out the potassium. And coming here, this is the alpha cells, so it has the same function as alpha intercalated, and this is beta cells. Beta cells is straight opposite to what alpha cells do. They push out the bicarbonates and reabsorbs the acid. Now coming to what actually happens in renal tubular acidosis. There are 4 types of renal tubular acidosis. They are named 1, 2 and 3 based on the discovery. So which was discovered first is renal tubular acidosis 1, and then which was discovered 2 is renal tubular acidosis 2. We will majorly only talk about 2, 1 and 4 because 3 is nothing but a combination of 1 and 2. So coming to renal acidosis 2 first, because that happens in the PCT. So what happens here is when almost 70% of the bicarbonate is reabsorbed in PCT. So when the cells are not capable of reabsorbing it, what happens is it just flows through the lumen of the nephron and is excreted. But to compensate the 70% which may have come down to around 20%, to compensate that, this alpha intercalated cells, they start producing the bicarbonates from the bloodstream. They take in carbon dioxide from the bloodstream here, and then they make the bicarbonate. But the problem here is almost the major bicarbonate reabsorption happens in the PCT. So the alpha intercalated cells are not that equipped to reabsorb most of the bicarbonates. So there is a decrease in bicarbonates leading to acidosis in the body. Next, coming to this is what happens in renal tubular acidosis 2, wherein NAGMA is nothing but non-anionic gap metabolic acidosis. This means that when there is a lot of bicarbonates that is present in the lumen, which is not getting reabsorbed, what happens is to compensate the negative signs there is an imbalance in the lumen. So to balance that, they push in. There is an imbalance in what comes to the circulation because bicarbonates is not getting through into the circulation. So what happens is they push in the chloride ions, which will be compensating in place of bicarbonates. This is not actually supposed to be there, but it's just compensating to balance the acid-base balance. So this is called non-anionic gap metabolic acidosis. This happens in RK2. What happens in with potassium is that when the bicarbonates are not being properly reabsorbed, what happens here is to compensate the bicarbonates that are present outside the cell, they push in a lot of potassium outside the cell to balance the acid-base balance in the lumen. So that is why there is a decrease in potassium in which is reabsorbed. Next, coming to acute and chronic. Acute and chronic is nothing but in acute, what happens is there is reduced bicarbonate that is going into this blood circulation. So there is a lot of bicarbonates that's dumped to DCT and CD, that is collecting that, and it's not able to meet up the bicarbonate that's lost. So there would be more dumping than the one that's getting created in the alpha intercalated cells. And in chronic, what happens is to begin with there is very less bicarbonate that is sent to the nephrons to be reabsorbed. So that is then in that time the alpha intercalated cells are able to meet up with the demand, and so dumping is equal or almost equal to what is created, what bicarbonate is created inside the cells. Then Fanconi syndrome. This is a syndrome wherein not just bicarbonates but other molecules such as phosphate, amino acid, uric acid, and bicarbonates are not reabsorbed to the amount that is required. And in such cases, if you find that the urine cultures have a lot of phosphates or amino acid or uric acid, you can check for if he has or she has the Fanconi syndrome, which may lead to renal tubular acidosis. Next, coming to RTA1. RTA1 happens in the distal convoluted tubule. Herein, the required amount of bicarbonate is reabsorbed in the PCT, but then the alpha intercalated cells are not able to meet up with the demand. What happens here is that there is the same thing as there is a decrease in potassium because the acid-base balance inside the lumen is being met by pushing the potassium into the lumen of the nephrons. Now what happens, another thing is kidney stones that happens here. The problem is that since the DCT which comes after PCT is not able to meet the demands of the rest of the, suppose 70% is reabsorbed here, the rest 30% is supposed to be reabsorbed by the DCT and it's not able to. What happens is they start increasing their capability. Suppose from 70% they go on to reabsorbing 80%. And when they reabsorb 80%, what also happens is they start reabsorbing citrate, which is in the lumen. So why citrate is reabsorbed is because this can be metabolized into bicarbonate in the liver. So they can meet up the body's demand of bicarbonate. But the fallback of absorbing citrate is that in the lumen the citrate is with the calcium in the solution, that is the lumen solution, and so there when citrate is reabsorbed into the bloodstream, the calcium starts precipitating out of the solution, so that may cause kidney stones. So that is one significant factor in RTA1. Now, this is mostly caused due to autoimmune diseases, which can be rheumatoid arthritis, lupus, or Sjogren's syndrome. Next, coming to RTA4. RTA4 happens in the collecting duct. Here, the major thing is again that the alpha intercalated cells are not able to function, but one of the outcome of it is that ENaC. ENaC is nothing but epithelial sodium channel, which takes in sodium and pushes out the potassium into the lumen. What happens here is that there is, mostly in diabetic nephropathy, there is reduced renin production, and because of that the aldosterone production is also reduced, wherein the aldosterone zinc function is to, they actually produce the ENaC channels. So when this is reduced, the number of sodium that is here increases. And when there is a lot of the positive charge, like in the magnets, when there's a lot of positive charge, the acids and the potassium are not able to be in the lumen. So what happens? This starts getting reabsorbed, and there's increase in potassium level and increase in acid levels. So that is why In RTA4, it is also called as hyperkalemic RTA, which increase in potassium level, and it is caused due to diabetic nephropathy. So yeah, that's it. And then treatment. So in treatment, mostly you have to meet up with the reduced bicarbonate levels in the body. So oral bicarbonate, which can be sodium bicarbonate or potassium bicarbonate, which can be given 1 to 2 MEQ per kg, and then potassium citrate only in patients with hypokalemia, and nephrolithiasis and nephrocalcinosis, wherein kidney stones are also present, and then high dose of sodium bicarbonate, if it is more than 10 mmol per kg per day, is given in type 2 RTA, wherein there is no bicarbonate absorbed, because 70% of the bicarbonates are absorbed in the PCT. So the demand is not met at all, not even in a slightest. So that's it.